Welcome to the Pain Science Education Podcast, where we discuss ways to treat and reverse persistent pain. I'm your host, Dr. Joe Tatta, a licensed physical therapist and founder of the Integrative Pain Science Institute, where we train practitioners on whole person pain care. This podcast also serves as a public health campaign to support those living with chronic pain. This podcast is for informational purposes only and is not intended to be a substitute for professional medical advice. Hi there, and thank you for joining me for this week's episode of the Pain Science Education Podcast. Today, I'm joined by Dr. Tash Pocovi to discuss her groundbreaking research on preventing lower back pain. Dr. Pocovi is a physiotherapist and a researcher who recently published a randomized controlled trial in the Lancet investigating whether a walking program combined with education could serve as a low-cost, accessible prevention strategy for those with prior low back pain. The WalkBack trial included 24 physiotherapists who prescribed individualized walking plans to mostly sedentary participants. The results were major reductions in lower back pain, care seeking, and work absenteeism, all which are major wins for both individuals and our healthcare system. Tune in to learn more about this exciting research, and don't forget to share this episode with your friends and colleagues. Okay, without further ado, let's begin, and let's meet Dr. Tash Pocovi. Hi there, Tash. Thanks for joining me on the podcast this week.
No, thanks for the invitation, Joe.
I'm excited to talk to you, and you can walk us all through your research, so to speak, around back pain. I know you published a randomized controlled trial in the June 2024 Lancet on the effectiveness and cost effectiveness of a progressive walking program and educational intervention for the prevention of low back pain. There was an Australian population, but I'm excited to talk about it for all of our listeners and viewers here on the podcast. Back pain is something we talk about often, obviously something that's explored often in the research and we see in clinical practice. What led you to look at walking? It sounds so simple, right? We all do it, or most of us do it, or should be doing it. Why walking for back pain?
Yeah, great question, Joe. And I think I just need to start by saying wonderful pun, in those first one or two lines regarding walking. I do appreciate that. But yeah, I guess probably deserves a little bit more background than just jumping straight into walking. And really our interest was in prevention to start off with, because in terms of low back pain, there is so much research done in the space of treatment. But what you see clinically is, yes, you'll treat most people and treat them well and send them off on their merry way, but then they come right back fairly quickly. So I work really closely with Professor Mark Hancock. He's a leading researcher here in Australia and was actually my PhD supervisor. And he was probably one of the first people really interested in this space of prevention. And what we wanted was really sensible estimates of how frequent is recurrent low back pain, how much is this actually happening? And what we found was that for people who had recently recovered from an episode, you're at about a 70% chance of having a new episode within the next 12 months. So that is really quite profound, particularly when you're thinking not only the impact to the individual who's suffering that low back pain, but think about the burden and the toll that takes on the healthcare system and the clinicians kind of treating those people. So for a whole bunch of reasons, we were really drawn to, well, how can we prevent recurrences? And so there's been a little bit of work done in prevention, but really a scarcity when you compare it to treatment. And I guess the thing that keeps coming up, and it's funny because it comes up in a lot of areas of pain research, is really our best bang for buck is looking at exercise, and particularly if it's combined with education. So going down this rabbit hole of what exercise works and doesn't, things like Pilates and those sorts of things have a little bit of evidence, but we really struggled with how accessible are these exercise formats. So sorry, this is a very long-winded response as to how we got to walking, but after talking to consumers and kind of getting feedback from previous trials and people's really adherence to programs, we knew that patients needed something that was accessible, low cost, simple in terms of, not a complex intervention, and not requiring, loads of equipment or supervision. So for a whole bunch of reasons, we thought, are we just overcomplicating things? Can we keep it really, really simple if it's just exercise? And so, yeah, Mark had put in a grant for the WalkBack trial, which I guess is largely what I'm invited to talk to today, where we were looking at a progressive and individualized walking program for preventing low back pain recurrences. So yeah, that's the kind of how did we get here story.
So we appreciate simple on this podcast because so often you hear pain is complex. Pain is complex. I think that message has percolated out there, and I think as clinicians we can say, sure, pain is complex, but does the treatment or prevention of pain have to be complex? And I think your research starts to point to, well, maybe not so much for people. Um, Other than walking, because we'll talk about it obviously in a few moments, is there anything else in the research as far as exercise that is useful for prevention?
Yeah, so there's not much done in terms of exercise, and really the stuff that I could quickly kind of exclude in terms of benefit are non-exercise based. So, there's stuff about back braces, shoe inserts, ergonomic changes at work, education alone. Those things don't have substantiated evidence to suggest that they actually help with prevention. There was a study done prior to my own and part of our same group looking at McKenzie-based exercise for prevention of recurrence, which is probably interesting to some of your listeners, given the audience. And, for that, it was a very small dose. It was 2 sessions of McKenzie-based therapy with a very much preventative lens. So self-management, here are your exercises, do them at home type thing. And really the only impact that we found compared to education alone in that instance was reduction in care seeking. So future episodes leading to care seeking. So maybe we weren't stopping all recurrences in that case, but we were actually better equipping people to stop seeking care and better self-manage, which really has become a big part of our kind of work, that self-management component, because ultimately that's how we're going to curb people's health behaviors, I guess.
Yeah.
But yeah, so very minimally, unfortunately, done in this space. A lot of regimented kind of core focus, let's call it, for the lay listeners. And again,
Core
delivered
exercise
by,
programs,
yeah, core
core
exercise
training
programs.
exercise programs for back pain, so to speak.
Yeah, and other things like flexibility. There's no real evidence for that. So yeah, it's pretty scarce out there in terms of what's available.
And we should maybe just maybe differentiate. So because you mentioned education, and I know education was part of your randomized controlled trial, but I think when you're talking about things like back schools, so to speak, don't have good evidence to support that they can prevent back pain.
Yeah, correct.
Does something like pain neuroscience education, would you put that in the same category?
I would say what we provided kind of sits maybe a little bit in the middle. It wasn't the intensive kind of pain neuroscience delivered by like the Lorimer Mosleys of the world, etc. So it was light touch in that respect, but it definitely stemmed further away from just the pure biological basis of pain. So maybe worth just touching on what ours kind of looked like in terms of education. I would say that a big focus of our education was actually just reassurance, and it was really around getting people comfortable with exercise, because these were people who had recurrent back pain, and upon talking to them they almost stopped exercise because they thought that's likely to stir me up, that's really going to give me more grief. The last time I had an extravagant episode of low back pain that left me floored for a week, it was after doing intensive exercise. Like, I'm not going near that. So I think it was a lot of managing people's expectations and anxieties around exercise, and I really think just partnering with people to understand that better, and that message that I'm sure you've repeated to your listeners quite a few times of more pain doesn't necessarily mean that you're doing more damage, and it takes time to build resilience and strengthen these muscles, so let's partner in this together. So yeah, our approach was not a formal teacher student setting. It was much more casual than that. It was very much partnering, using a lot of health coaching type techniques to get people on board with our program.
Yeah, so I think we should maybe you can walk us through the walk back intervention, so to speak. And of course, we'll talk about some of the results of the trial, but I guess, a lot of practitioners file and they'd like to know probably like what does this intervention look like, so to speak? Because you did use physiotherapists to in this trial, is that right?
Yeah, correct. So we recruited just upwards of about 20, I think 24 was the exact number, of clinicians across Australia to deliver this intervention. So it was in a private practice setting, so not a hospital setting or rehab setting, anything like that, private practice. And yeah, I guess in terms of the intervention, as I mentioned, it was an individualized and progressive walking and education program. So in terms of the population that we recruited, just to give you a little bit of an idea, they were very much sedentary in nature. So we consciously excluded people who were already, involved in large amounts of walking, who were doing, reaching the kind of recommended thresholds of moderate and vigorous physical activity, so more than 150 minutes per week. So just to give you an idea, these were people that were really quite sedentary. And so in terms of the program, the way we went about the intervention was, well, we can't just tell people go and walk 5 times a week for 30 minutes because we know that health behaviors are hard to change and it's really difficult to get people physically active. So what we came up with, and I think the clinicians quite liked using it, at least as a conversation starter, was we called it, a prescription matrix. And you can actually find it in the appendix to the main paper. So it's open access and anyone can go and access it. But what we said to the clinicians was based on each patient's or participant's response to how much are you currently walking, what's your age, your BMI, and do you have any other comorbidities that we need to consider? This is your starting walking prescription, and this is your tentative walking prescription in a month's time. Now, remembering that I framed this all around health coaching, and a lot of health coaching is, really diving into what patients want, need, how's the program actually going to fit within their daily lifestyle, etc. This was completely just a conversation starter, and then it was really the role of the physio to discuss with each participant, well, how are we going to make this work? Is this actually feasible? Mm-hmm. So I think the lowest category that we had in there was like the red zone or something, and it was like 2 to 3 10-minute walks in the first couple of weeks. So really something quite achievable, attainable. And the idea was, well, if we set you up for failure early, you're going to get demotivated and not hit these targets. And we really want it to be a lifestyle change. We don't want this to be, a 6-month program that you're involved in and then never do it again. So that was the kind of intent behind it. And in terms of our proposed dose, let's say, we wanted people to, by the end of the 6-month program, get to walking most days of the week for about 30 minutes. So that was our end target. Some people exceeded it, some people never reached it, but that's what we were aiming for. I've already spoken a little bit about the education, but in terms of the delivery of both the prescription, the walking program and the education, it was delivered across 6 sessions across a 6-month period. Now, it was a little bit more bulked at the beginning, so people need, a little bit more attention, a little bit more assistance, troubleshooting in terms of any barriers that people might, encounter along the way. So, it was like 4 sessions in the first 2 months, mm-hmm. And then scattered a little bit less frequently across the 6 months. But hopefully that answers your question in terms of a bit of an idea about the intervention, but happy to answer anything specific.
Yeah, so so you're initially doing, so physiotherapist is using some basic principles of health coaching to help people access why this is important for them, and then to slowly but somewhat progressively increase their walking, essentially.
Yeah, and you just reminded me in terms of the health coaching, we picked physios for a few reasons. And one was that we felt that they would be able to effectively deliver the education component, because we do believe that it needs, some sort of therapeutic background in that and understanding of pain science. So a good reason to choose physiotherapists. And 2, we just maybe biasly so because I'm a physiotherapist myself. But felt that the health coaching is kind of up our alley. Now, that's not to say that all the clinicians, practicing are great at health coaching, and we actually provided a limited amount of training. So it was about, sorry, 5 hours or so of kind of training, most of which was online modules. And we partnered with a wellness coaching organization here in Australia to kind of tweak their content to suit our cause. But yeah, it wasn't massive amounts of training that clinicians required, because I know some of the trials, and rightfully so, something like Restore, chronic low back pain, very complex intervention, lots of components. I think those clinicians had something like 60 hours worth of training.
Yeah, that's a lot. It's a lot of hours.
Yeah, and a lot of them were contact hours, I think. So again, different strokes for different folks. For something so complex, that's probably what you need. But considering what we were trying to deliver in our intervention, a more simplistic and let's call it less full-on approach was required.
Yeah. And I guess for like tracking purposes, so obviously the physiotherapists are providing them with some basic education and some guidance, some support, coaching. Were the physiotherapists tracking how much they were walking, or what did that look like?
Yeah, great question. So we asked participants in the intervention arm of the trial to actually maintain a walking diary. So we provided it with them. It was a hard copy, kind of, write things down type of approach. And what we were asking them to document in that walking diary was two things. One was the minutes of intentional walking done per week. So that is, I know I'm in the WalkBack trial. I'm going for a designated WalkBack trial walk. So it's not enough to just, wander into the kitchenette and, say, yeah, that's an extra 3 minutes there. It was very much something about intentional. It's for exercise. It's not just leisurely activity at that point. So we were asking people to document the frequency and duration of each of those walks when they went for them. And then we also supplied participants with pedometers. So, just hip-worn device, how many steps are you doing each day? And that was a daily reporting of that. But looking at some of the step count data, people were a little bit hopeless at recording that in comparison to the frequency and duration of the walks. So I have much more trust in that data than the step count data. And we were on a trial budget as well. So the pedometers we had probably weren't, equivalent to your smartwatch or Fitbit, which funnily a lot of people used instead, those readings. Yeah.
Any idea how many steps people were hitting on average in the study? Because there's lots of research and interest around how many steps per day helps someone, maintain optimal health or longevity. Were steps step count followed in this trial?
Yeah, but not for the daily step count. So not in relation to the walking diary data. We did send out actigraphs, so activity monitors, research grade ones, let's say, 3 months into the trial, and we sent it to both groups, so the intervention and the control group, just to get a little bit of a comparison between those two arms. And it wasn't a huge amount of difference between the walking and let's say the control group, which was no intervention in this case. At that point, it was about a 700, sorry, I'm getting over a cold, about a 700 step difference per day. So I guess that perhaps adds up over the week or over time, but it wasn't a huge difference in steps. Yeah.
That's at the 3-month period though, because some of your study looks like it went out almost 2 years.
Yeah, and that was tracking. We tracked different outcomes for different amounts of time. So, if we were asking people for 3 years is actually the high end of when we had data collected. But that was for our primary outcome. So our primary outcome had to do with preventing recurrences of low back pain. And for that, we followed people for up to 3 years or a minimum of 12 months. Or until they, first had our episode of interest. So I don't know if that's a nice segue to talk about what our outcomes were.
It sure is. So yeah, tell us what the outcomes were.
Yeah. So in terms of primary outcomes, I was kind of talking to it before, but we can measure low back pain at, let's say, different thresholds or recurrences at different thresholds. And our group is particularly focused on 3 different thresholds. And maybe I'll just try and talk you through that. So the first one is kind of our most minimum threshold. So have you had low back pain, between base of the ribs and buttock crease for a minimum of 12 hours, and was it more than 2 out of 10 pain on a numerical pain rating scale. So really not a high threshold to reach. Our second one, which was the primary outcome in this trial, was an episode leading to activity limitation. So meeting the same as the minimum threshold, but this time we asked the participants on top of that, on a 5-point scale, how much did this episode of low back pain actually impact your daily activities? And that ranges from not at all through to very much. And we say anything that sits in the middle, so somewhat or greater, meets the definition of an activity limiting episode. And then our third definition, which we use quite regularly and quite like, I spoke about it in that McKenzie trial, is care seeking. So do you have an episode that's bad enough that requires care seeking? And again, meeting those minimum thresholds of the previous ones. But yeah, so in WalkBack, we used an activity limiting episode. And what we were looking at was time until the event. So from when you were randomized, and we randomized people fairly shortly after they'd had a previous episode. So you needed to be recovered, since what we were tracking was recurrences moving forward. How long does it take for you to have your first episode meeting each of those definitions?
And the difference between the trial group versus the control group, there was a difference, right?
Yeah, correct. So for our primary outcome, what we actually found was we translate this into a hazard ratio. So I'm not sure, I'll give a brief kind of understanding of that. But in terms of hazard ratio, it's a composite measure. So it's a measure of, did you have the event? Yes or no. So in this case, did you have a recurrence? Yes or no. And also the time taken to have that recurrence. So it's a bit of a, did you have the outcome, and a component of time. What you end up with comparing the groups is a hazard ratio. So if you have a hazard ratio of 1, that's no difference between the groups, right? So in our trial, what we actually found was a hazard ratio sorry, of 0.72. So that was what that 72 equals is, a 28% relative risk of having a recurrence if you were in the intervention group compared to if you were in the control group. So really quite substantial. And although it wasn't our primary outcome, even looking at the care seeking, so reducing a recurrence of care seeking, that was quite profound. We found a 43% risk of reduction in that group. So yeah, again, going back to think about the difference that makes to a healthcare system burden, as well as the burden on the individual. I think profound findings for something so simple.
Yeah, the care seeking stood out to me when I read through the paper, because we know that the treatment of back pain, the care, the evaluation, care, and treatment of back pain is billions of dollars for healthcare systems. And as you mentioned, there's a financial burden there, but there's also a burden on the individual with pain and suffering, lost time at work, their financial burden, so to speak. Talk to us, about some of the economics of this topic, and what your study starts to kind of point to as far as, on the dollars and cents, so to speak. What does this really mean kind of in a real life, kind of more pragmatic way?
Yeah. So look, based on recent estimates, and I can't speak to the exact numbers in the States, but in Australia, we're talking about $3.2 billion annually spent on managing back pain. So the numbers, again, are just huge in terms of the financial toll it takes on the healthcare system and individuals. So we did have a cost effectiveness component of this trial. And what that involved was we asked our participants to actually report on, costs associated with the care of their low back pain across a 12-month period. So the main cost that we were looking at was costs related to work absenteeism. So, did back pain actually cause time off work, medication use, care seeking, as in, physio, chiro, GP settings, anything like that. And then specifically any hospitalizations that are a result of low back pain. And so what we do is we put prices, average prices, because things cost different depending who you go and see, and, for how long, etc. But we, costed all those things. And what we did was, again, compare between the intervention and the control. And what we actually found that our intervention was actually cost effective. So we tend to place willingness to pay thresholds is the official term. So, based on policy and kind of government recommendations, etc., how much would policymakers be willing to pay for a 1 point improvement in a quality adjusted life year? So this has to do with, how much improvement the person has, the costs associated, etc. And so, based on that willingness to pay threshold, we actually found that our intervention and how much it costed in the end was actually at about a 95%, likelihood of hitting those thresholds. So highly likely to be cost effective, I guess, if I try and simplify that as much as possible. But delving a little bit deeper into that cost analysis, where we really found savings in terms of the intervention was time off work. So people were having less time off work as a result. That was the biggest difference here. So yeah, that's probably the nice little summary there.
Yeah, which is an important difference because employers are very interested in ways that they could, um, one, help their employees manage pain, but two, of course, control costs. Because I mean, at least in the United States, there are self-employed plans where employers are purchasing the health plan and they're looking at what they're spending the money on actually, and they're finding, wow, we're spending so much money on musculoskeletal pain, specifically back pain. So I think things like this, start to point employers to the idea that physical therapy supported interventions or health coaching supported interventions in this case um, can have a place in the care of people with pain, so to speak.
Yeah, and I'm hoping that extends to health funders too, because I'm again not entirely across how the system works in the US, but funding models in Australia don't support preventive care.
Yeah.
We support chronic disease management, and you'll have funded sessions, and they're needed. Don't get me wrong, but perhaps we can nip the problem a little bit earlier in that chain, before people get to the point of chronicity. So yeah, it's I'm hoping, that the hype around the trial, and it really has been hype. It's been astounding to see how much interest we've gotten, not from only research circles, but the public, in regards to this trial. And I think it's because it's relatable. It's simple. We haven't, overcomplicated things. And, I've had a question been asked quite a few times, and it's so simple. You started the podcast with it, right? I remember being on a radio interview, and a caller had said, why on earth did it take 20, 30 years for you guys to figure out that walking worked? And I think it's just because there was this belief that it probably did work, and no one, we're glad we stumbled across the opportunity and decided to pursue it. But yeah, I'm really hoping that not only does this shed a light on the importance of physical activity and the place that kind of health coaching has, but really a shift in preventive care. I think that's what I really want to come out of this, because there's been some qualitative work, even here in Australia, looking at, how comfortable are physiotherapists in prescribing preventive exercise. And, the findings were a bit of a surprise to me, that they're not all that confident in doing that. And one or a couple of the reasons, the first one was a real uncertainty about what the evidence says, because there's just such a scarcity of it. So hopefully our trial does one step better on that front. And the second is, or an extra two things. One is a discomfort with providing preventive care to people not in pain. So as a physical therapist, someone presents acutely with pain. Yes, you fix them. And then I don't know if it's a reservation of asking people to pay you more or to see you more regularly. I get the kind of reservations with doing that. But actually, best care is to try and really get this person self-managing well, able to prevent future recurrences, and then not seeing you again. Or that's my lens anyways.
I
So
think
yeah,
that's a really good point though, because it's kind of like you have a cavity, you go to the dentist, the dentist fills the cavity, and then he or she says, I'd like you to come back every 3 months for cleaning, and in the meantime, I want you to make sure you brush and floss 3 to 4 times a day, so to speak, and I'm going to connect you with my dental assistant who's going to give you some tips and tools on how to do that, basically. And I think what you're saying is really salient, because it's like in physiotherapy, Someone comes in with an episode of low back pain. We target and treat the back pain. We hope that it goes away and someone's function increases. And then we kind of send them along their merry way, so to speak. But I think what you're saying is this is an opportunity to say, hey, here's where you can maintain contact with that person and help them prevent coming back again for a whole nother episode of care, so to speak, which has positive implications, so to speak.
Yeah. And, positive implications beyond their low back pain management, I think is the nice thing. So, I'm kind of just picking pieces of different kind of studies I've been involved in. One of which was to do with the WalkBack trial, but what we did was we actually interviewed a sample of participants who were in the intervention arm of the trial. And it was so lovely to see that they were saying, well, one, yeah, I'm better managing my recurrences of low back pain. Like I feel like I'm having less episodes because obviously we didn't have the data to kind of support this. This is just what the participants were saying at that point. I feel like I'm having less episodes, or if I do have an episode, it feels far less severe, or I'm able to recover more quickly for it. So instead of it lasting, a week, it's 1 or 2 days and I'm back on my feet and back to normal routine. But outside of all of those things, I'm sleeping better. I'm less stressed. I'm, better managing other comorbid health conditions. I've lost 20 kilos, like just all these other health benefits that just come with a more physically active lifestyle. And so, we know based on previous research, walking or physical activity, full stop, but let's just talk about walking here, is great for managing so many things, right? And it kind of just looks like we can add preventing low back pain recurrence to one of those.
Yeah, so we can prevent our low back pain, plus we can improve our physical and our mental well-being, which I think is really important. Next steps for you in this work, what would our next steps be?
Great question, and one that I am still trying to tease out, to be honest. So we have, sorry, a whole bunch of data that we can look at, and one of the things we're interested in is, well, does the intervention, because what I've reported is averages, right? In some people, it would have worked really well, more than that 28% reduction, and in other people, it wouldn't have worked at all. And so really teasing out, well, which characteristics of a participant, does it depend on their age or their gender or their level of education? Does that curb the amount of benefit that you see downstream? So that way we can really target this intervention, and we might not find any difference between groups, in which case that's also great news. It works on everyone and prescribe it to everyone. But I guess that's one quick kind of area of interest. But ultimately, I want to see this rolled out in clinical care. And I'm not entirely sure the best way to go about that. But there needs to be some work done in implementation, because, it was cost effective in terms of it reduced the overall costs, let's say, or the overall burden on people throughout the trial. But there was still a cost associated. You're seeing a physio for 6 sessions, and it was roughly $350 is what we paid on the patient's behalf. So in real world, will a patient be wanting to spend that money? I don't know. That's still up in the air, right? So I would love to see it rolled out, but I think in the scheme of things, it is low cost. Think about a gym membership. Think about seeking care for your low back pain for future episodes. So for a whole bunch of reasons, we kind of need to look at how does this get weaved into care. But one element that hadn't come up in the interview, but I think is a really lovely part of our story with this trial, is it happened during COVID. We recruited for, I think, 3 or 6 months, and then we went into complete lockdown here in Australia. And the 20 clinicians that we trained up, initially we said, of those 6 consultations that are the intervention, 3 are going to take place in your clinic. And then 3 will be quick touch-based phone calls, right? And so COVID completely tipped that on its head. And we had to change tactics really quickly. And so we consulted with the physiotherapist and we said, hey, do you reckon you can deliver this via telehealth? Are you guys confident enough? And do you think you'll be able to, really maximize the sessions, even if it's done via telehealth? And we had the physios on board. And so we obviously did a bit of a trial period and see how it all went. And that was an absolute game changer for us, because initially we were recruiting based on geographic location. So if a participant or potential participant didn't live nearby, that was a complete write-off, and they couldn't be involved in the trial, to, in fact, when we went telehealth, we recruited Australia-wide, and we managed to access people who really lived in quite rural or remote locations who otherwise never would have accessed this care. So I think there are a lot of positives about this intervention, and it's us just trying to figure out the best way to kind of proceed with that. But yeah, another funny thing, and it might just be of interest to your clinicians, is a lot of them in the end actually preferred the telehealth delivery to the face-to-face, which I was a little bit surprised by. But they said when the participant walks into a clinic, sees a plinth, sees exercise equipment, there's almost this automatic thought, particularly when they see that the physio bed or the plinth, that there's going to be some manual, hands-on type therapy, whereas that was not the goal of this intervention at all. So that telehealth provided that barrier and made it explicitly clear that this is not a passive intervention. This is you as the patient or the participant really need to be an active player in this. And it was very much conversational at that point. It was, no hands-on. So yeah, it was nice to hear that from the clinicians. I'm glad that they had that experience.
Yeah, I mean, I love that. I think we should all be embracing telehealth. And I also think, as you mentioned, COVID kind of changed your approach, so to speak, where people had to use telehealth. But I imagine it kept the clinicians from drifting away from the protocol, because that can happen sometimes with new interventions where clinicians come in, they get trained on something new, like cognitive functional therapy, let's say, and they're excited about it. And then over time, it kind of drifts and they kind of drift back to their old ways. But this kept them clear about what they were doing. And also, like you said, you don't necessarily have to have a physiotherapy clinic for that. You can do it from home on the phone, or you can do it via Zoom or another platform, which I think is really important for physiotherapists and other people to talk about. Dr. Pocovi, it's been great speaking with you today on the Pain Science Education podcast. Please let our followers and listeners know how they can learn more about you.
Yeah, so I'm very much a new researcher, so I don't have an established website or anything like that. But yeah, Twitter sphere is probably the best way to catch me. So at Pocovi Tash, so Pocovi and then Tash. But yeah, I assume you can link people up in the show notes or something and make that spelling disaster a bit easier for people.
Yes, we'll definitely include the link to Twitter in the show notes so you can all access it. We'll also include a link to the paper, which you can find in the June 2024 Lancet on the effectiveness and cost effectiveness of a progressive walking program and education for the prevention of low back pain. Dr. Joe Tatta, please make sure you share this episode with your friends and colleagues who are talking about the prevention and treatment of low back pain on Facebook, LinkedIn, Twitter, wherever you're playing on social media. You can find me there at Dr. Joe Tatta. Thanks for being with us, and we'll see you next week. Thank you for listening to the Pain Science Education Podcast. To subscribe to the podcast and learn more, visit integrativepainscienceinstitute.com. That's integrativepainscienceinstitute.com. Sign up to receive weekly updates and learn about our continuing education courses. If you enjoyed this episode, leave us a review on your favorite podcast platform and share this episode with your friends. Please join us next week as we share more science-backed solutions for treating and reversing chronic and persistent pain.